Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here today to explain amyloidosis in the context of ophthalmology. Because the eye is an organ that perceives light, the structures are very fine, and therefore the vasculature that supplies the tissues within the eye is very delicate as well. So any blood abnormalities, any alterations in the vitals of the blood can cause disorders within the eye as well. New vessel growth in the iris, retina, and the optic disc due to, for example, hypoxia can be fatal to vision. And increased permeability in the vascular wall, endothelial cells, or the increased viscosity in the blood contents can lead to pathologies in the retina. Toxic accumulations of misfolded proteins can also cause damage to the eyes. So let me introduce this disease called amyloidosis. This is a collection of diseases that is defined by the accumulation of abnormal proteins and the deposition of said proteins in various tissues throughout the body. This can be related to multiple myeloma, which is a cancer in a type of white blood cell called plasma cells. The familial form of amyloidosis, the one that's passed down generations, this involves substitution errors in the DNA sequence that's involved with coding prealbumin. Prealbumin production is in the liver, the choroid plexus of the ventricles of the brain, and enterochromaffin cells in the mucosal walls of the GI tract. When this becomes activated to albumin, it plays an important role to maintain appropriate osmotic force within the blood. And albumin can also act as a carrier protein for the various substances as well. Here is a stepwise pathophysiology of how amyloidosis can present as a disease in the body. So first, abnormal extracellular hyaline material is produced in the body, and these misfolded proteins happen to be insoluble, and they can accumulate in the end organ tissues throughout the body. Because they're insoluble, they can easily come out of solution, and they can clump together as well. And on the eyes, these amyloid proteins can accumulate on the adnexa, extraocular muscles, conjunctiva, cornea, lens, trabecular meshwork, which are exit points for the fluid produced within the eye, and vitreous and retina as well. So pretty much all over the eye, there is a possibility for amyloid proteins to accumulate. The risk of an individual presenting with amyloidosis is increased by several factors. As an individual gets older, specifically over age 40, that would contribute to a higher risk factor of amyloidosis. And there is more prevalence of this disease in the males or in the females. If someone has multiple myeloma, because these two are ultimately associated with the production within the blood, or more specifically the bone marrow, there is a higher chance of an individual also having amyloidosis as well. And lastly, family history can be a big factor. As we've covered earlier, there can be alterations in the DNA sequence that is responsible for producing prealbumin. The symptoms of a patient with amyloidosis can be first in the orbit, a feeling of mass infiltration, ptosis, or the closing of the upper lid, diplopia or double vision, as well as irritation in the orbital region. Visual field loss can occur as well when the amyloid proteins accumulate near the optic nerve. In the conjunctiva, yellowish waxy lesions can be observed. Amyloidosis can present in the cornea as well in the form of corneal dystrophies, and some examples of that are the gelatinous drop-like corneal dystrophy. The stromal layer of the cornea can be altered abnormally as well, and the amyloid can also be deposited in the corneal layer and the conjunctival layer continuously. Floaters may be seen as the amyloid infiltrates the vitreous, and decreased vision overall can develop as amyloidosis progresses. With the slit lamp exam, the vitreous involvement is the most common in the case of amyloidosis, and it would usually be presented as a pathology of the granular glass wool opacities within the cortex of the vitreous. In the vasculature of the retina, there may be occlusions with the accumulation of the abnormal proteins, cotton wool spots resulting from the localized ischemia, and neovascularization in the retina as a result of that. Because the retinal tissues can't receive enough blood supply, there may be, in advanced cases, abnormal angiogenesis. Compressive optic neuropathy is also a possibility, as discussed in the previous slides. Eyelid hemorrhages and ptosis, as well as the anterior displacement of the eye called proptosis, as illustrated in the rightmost picture, can be observed as well. And with the abnormal accumulation of proteins, they may dry out the eye. With the proptosis and other factors, the extraocular movement may be compromised, and the iris will have infiltrate as well. Systemic signs of the amyloidosis, other than the eyes, include polyarthralgia, or the pain in the joints, pulmonary infiltrates on the X-ray, waxy maculopapular skin lesions, also renal failure, and GI bleeds. They are all possible with amyloidosis. With patients presenting with something that looks like amyloidosis, some differential diagnosis must be entertained. These include, for infectious diagnosis, papilloma. Inflammatory can be other infiltrated diseases like sarcoidosis, neoplasms like lymphoma, leukemia, squamous cell carcinoma, Kaposi's sarcoma, as well as metastasis can present similarly. And for vitreous presentations, we should rule out asteroid hyalosis, vitritis, and old vitreous hemorrhage that appears to be amyloid protein accumulation. So for these patients, a good history taking is always indicated. Ask for specifically the family history of amyloidosis. On the slit lamp exam, pay attention to the iris, lens, and the anterior vitreous. Look for the lid malpositions like ptosis, and look for any globe displacements like proptosis. Test for extraocular movements and ask the patient if they see double vision at any point of the exam. Look for any mass lesions of unknown origin throughout the slit lamp exam. Investigations for amyloidosis includes the CBC and check the albumin as well, SPEP for multiple myeloma, and LFT or liver function tests, because albumin is largely produced from the liver, chest radiographs to spot any lung infiltration, and 12-lead ECG to see if the heart is affected in any way. Gold standard for diagnosis is by a biopsy. There are many modalities of treatment for amyloidosis from an ophthalmologic perspective. In the orbital region, attempted excision can be performed, although it will be hard when the accumulation is near the lacrimal gland. And just the partial excision may be enough for biopsy and diagnostic purposes, and observing, unless the function of the eye is compromised, may be appropriate for the orbital stage. In the conjunctiva, observe and lubricate would be the mainstay of treatment. If accumulation is persisting or uncomfortable or disabling, local excision and surgical debulking may be indicated. Increased intraocular pressure may warrant trabeculectomy. As we've discussed earlier, these abnormal proteins can accumulate in the trabecular meshwork. This is the exit point of the fluid within the eye, which is being constantly produced. So naturally, if the exit point is blocked, the pressure inside the eye may increase, which is very dangerous for sensitive structures like the optic nerve and the retina, and that could compromise vision in the long term. In the vitreous, the opacity detected may warrant pars plana vitrectomy. From the systemic perspective, we must target any infectious or inflammatory causes and look for any bone marrow abnormalities and production problems. Check if the patient needs dialysis as well, so that would involve measuring GFRs and creatinine. In the future, there are some promising therapies like tafamidis, which is a small molecule stabilizer. Intravenous siRNA formulations can also reduce mutant and non-mutant transthyretin. Lastly, new antisense oligonucleotides can lead to the hepatic production of the mutant transthyretin, and that could in turn suppress the mutated mRNA. That would lead to the decrease in the production of abnormal proteins that contribute to amyloidosis. So, as explained throughout our presentation today, amyloidosis do contribute to the link between hematology and ophthalmology. Here is a summary flowchart that organizes everything that we talked about today. Here is the reference, page 1, and this is the second page. Thank you so much for watching this video.